First, you need to know how to recognize bipolar I. Bipolar I is defined by mania. The only requirement for the diagnosis of bipolar I is a manic episode. So what is a manic episode? A manic episode is an elevated irritable mood plus increased energy, and it lasts for at least 1 week. Remember that timeline, at least 1 week. Or it could be a duration of any duration if hospitalized. So say they've been manic for 2 days, they go to the hospital, they get stabilized, it still counts as a manic episode. There must be at least 3 more symptoms from the dig fast mnemonic, which is distractibility, insomnia, grandiosity, flight of ideas, increased activity, pressured speech, thoughtlessness, which is risk-taking. Medical students commonly make the mistake of thinking that there must be major depressive episode in order to be diagnosed with bipolar I, but in bipolar I, only mania is required. Depressive episodes are not required. Bipolar I can also have psychotic features, which is delusions or hallucinations, which may occur in mania. Mania is so severe that it is going to cause significant impairment or require hospitalization to prevent harm. Let's contrast this with bipolar II disorder. So bipolar II is defined by hypomania and depression. It requires at least 1 major depressive episode and at least 1 hypomanic episode. So what is a hypomanic episode? Think of it as a little manic episode. It's not to the extreme of mania, but it still has an elevated or irritable mood, and the duration timeline is at least 4 days. So it's a shorter duration timeline than that of mania. Hypomania is different from mania in that there is no real marked impairment. It does not require hospitalization and it has no psychotic features. So you might have someone with elevated mood, less sleep, increased productivity, maybe they're talking faster than usual, but it's not going to affect their ability to function to the point where they need hospitalization. There is a high risk of misdiagnosis in people with bipolar II because there is that lack of dysfunction in the hypomanic episodes, and this is why it's so important in our review of symptoms that we screen for hypomanic episodes. There are some specifiers that you need to know for bipolar disorder. First is the rapid cycling specifier. This is defined by the occurrence of 4 or more mood episodes, manic, hypomanic, or depressive, within a single 12-month period. So think about 4, 1 for each season, within a year. The clinical significance is it is associated with a poor long-term prognosis, and it may require specific mood stabilizing strategies. Next, we have mixed features. This specifier applies when symptoms of both mania, hypomania, and depression occur simultaneously at the same time, nearly every day for at least 1 week. It's important to note that patients with mixed features often have a poor response to lithium, even though lithium is like the gold standard for bipolar. It's not as useful in those with mixed features, and they may better respond to anticonvulsants such as valproic acid or carbazepine. Cyclothymic disorder is often tested along with bipolar I and bipolar II. It is a chronic mood instability. The core feature is this alternating patterns of almost hypomanic episodes, but not quite. They don't quite meet full criteria, and mild to moderate depressive symptoms. The duration must persist for at least 2 years in adults and at least 1 year in children and adolescents. The individual must never have been symptom-free for more than 2 months during this period. So basically every single month for 2 years, they're going to have these mood swings between the hypomanic symptoms and the depressive symptoms. The diagnosis is excluded if the patient has ever met criteria for a full manic episode or a hypomanic episode. So if they've had something that meets criteria for either mania or hypomania, they cannot meet criteria for cyclothymic disorder. As far as prognosis, about 1/3 of these patients will eventually develop bipolar disorder. Now, it is important to note that these symptoms can sound very similar to the chronic mood instability of borderline personality disorder. Okay, so let's talk about management of bipolar disorder because it is so high yield on your exams. Lithium. Lithium is considered a gold standard. It is the only mood stabilizer shown to decrease suicidality, which is pretty awesome. However, it can be dangerous in pregnant women because it's associated with the Epstein's abnormality, which is a cardiac abnormality in the developing baby. We also have anticonvulsants such as valproic acid, clonazepam, which are great for acute mania. They are particularly useful in rapid cycling or mixed features, as we talked about earlier. However, they also are associated with defects. They can cause neural tube defects in the developing baby. Pay attention to the Epstein's abnormality in lithium and the neural tube defects in valproic acid because you will be tested on them. Lamotrigine is useful for the depressive phase, but it's not that useful in treating mania. And then we have the second generation antipsychotics, such as Quetiapine. Quetiapine is like the golden child for bipolar disorder because it can treat both mania and depression. And it can be useful as a monotherapy or as an adjunct. Now, of note when you're treating bipolar disorder, with bipolar II and sometimes bipolar I, there are depressive episodes, but we do not treat with antidepressants alone. Antidepressant monotherapy can risk switching the patient into a manic or hypomanic episode. This is so important why we screen for mania, hypomania when we are doing our initial interview with a patient that has depressive symptoms. All right, so let's talk about other interventions as well as monitoring. So ECT is highly effective for refractory mania or life-threatening depression. It is the best treatment for pregnant women who are in acute mania, as we talked about before. Both lithium and valproic acid can cause harm to the baby, so ECT is a good treatment option. Also, therapy can be beneficial. Supportive therapy, family therapy, especially helping have that support with the patient. Group therapies, they're all great alongside a medication. They cannot be treated by therapy alone. And if someone is forwardly manic, wait for the medications to kick in. Don't try to do therapy at that time. Now, lithium monitoring might get tested. There is a narrow therapeutic index. It requires regular monitoring of lithium levels. The target levels should be 0.6 to 1.2. You also want to monitor their creatinine, and that is because lithium can affect the kidneys. Valproic acid, on the other hand, can affect the liver, so you want to check liver enzymes with valproic acid. And you also want to check thyroid function if someone is taking lithium because it can affect their thyroid. You need to make sure that there are no medical causes or else you miss the root cause of these symptoms. For more high-yield videos, click on the playlist on the right. Otherwise, good luck on your exam.